Today we'll be discussing venous thromboembolism, including both deep vein thrombosis and pulmonary embolism. This is an important topic for anyone working in acute medicine, emergency medicine, general practice, or hospital medicine because VTE remains one of the leading preventable causes of morbidity and mortality in healthcare. Throughout this session, we'll use real-life clinical scenarios to discuss diagnosis, investigation, and management, with a particular focus on practical decision-making on the acute take. Before discussing diagnosis and treatment, it's worth appreciating the scale of the problem. VTE is extremely common and can occur both in hospital and in the community. The incidence rises significantly with increasing age, obesity, malignancy, and hospital admission. Many pulmonary emboli originate from deep vein thrombosis in the lower limbs, and a significant proportion of DVTs are clinically silent. One of the challenges with pulmonary embolism is that symptoms are often nonspecific. Patients may present with breathlessness, chest pain, collapse, or simply unexplained tachycardia. Because of this, PE remains underdiagnosed and should always be considered in the differential diagnosis of acutely unwell patients. A key concept in VTE management is determining whether the event is provoked or unprovoked. A provoked VTE occurs in the presence of a major transient risk factor, such as surgery, trauma, pregnancy, prolonged immobility, or hormonal therapy. An unprovoked VTE occurs without an obvious triggering factor. This distinction is important because it influences both duration of anticoagulation and future recurrence risk. Patients with unprovoked VTE generally have a higher long-term risk of recurrence and may require extended anticoagulation depending on bleeding risk and individual circumstances. Not all patients carry the same risk of recurrent thrombosis. Factors associated with recurrence include unprovoked presentation, active malignancy, inherited thrombophilia, proximal DVT, male sex, and increasing age. This becomes particularly important when deciding whether anticoagulation should stop after 3 months or continue long term. The decision always involves balancing thrombosis risk against bleeding risk. Many people think of VTE as an acute illness, but it can also lead to significant long-term complications. Following DVT, patients may develop post-thrombotic syndrome. This can result in chronic swelling, discomfort, venous insufficiency, and leg ulceration. Following pulmonary embolism, some patients develop chronic thromboembolic pulmonary hypertension, or CTEPH. Although uncommon, it is associated with substantial morbidity and can lead to progressive right heart failure if not recognized. When discussing VTE treatment, it is useful to think about two separate phases. The first phase is treatment of the acute thrombosis. The second phase is prevention of recurrence. For most patients, 3 months of anticoagulation is sufficient to treat the acute event. The challenge then becomes determining who can safely stop treatment and who requires longer-term anticoagulation. Heparin and warfarin remain important drugs despite the widespread use of DOACs. Low molecular weight heparin is still the preferred option in pregnancy and is frequently used in malignancy. Warfarin continues to have a role in patients with mechanical heart valves and certain thrombophilic disorders. Understanding when these older agents are preferred remains important in clinical practice. Understanding how these drugs work helps explain both their benefits and risks. The direct oral anticoagulants target specific components of the coagulation cascade. Apixaban, rivaroxaban, and edoxaban inhibit factor Xa, while dabigatran directly inhibits thrombin. Compared with warfarin, they provide more predictable anticoagulation, fewer food interactions, and do not require routine INR monitoring. This slide summarizes the major clinical trials that established the use of direct oral anticoagulants. The important practical message is that DOACs have become first-line therapy for most patients with DVT or PE. Different agents have slightly different initiation regimens. For example, apixaban and rivaroxaban can be started immediately, whereas dabigatran and edoxaban require initial heparin therapy. For acute physicians, familiarity with these dosing regimens is essential. When prescribing anticoagulants, pharmacokinetics matter. Renal function, age, body weight, and drug interactions can all influence drug selection. Always check renal function before prescribing a DOAC and reassess periodically during follow-up. Dose adjustment may be required in elderly or frail patients. Let's consider our first clinical scenario. We have a 70-year-old lady who recently underwent hip surgery following a fractured neck of femur. She now presents with pleuritic chest pain, shortness of breath, and hemoptysis. Immediately, we should recognize multiple major risk factors for venous thromboembolism, including surgery, immobility, and recent hospitalization. The combination of pleuritic chest pain and hemoptysis should strongly raise suspicion for pulmonary embolism. Her observations are relatively stable. This is an important teaching point. Most pulmonary emboli do not present dramatically. The absence of hypoxia or hemodynamic compromise does not exclude PE. Similarly, the absence of clinical signs of DVT is very common and should not reassure us. This represents a provoked uncomplicated pulmonary embolism. The diagnosis is suggested by the clinical history and confirmed through appropriate investigation. Recognizing the provoking factors is important because they will influence treatment duration. The best treatment option here is a direct oral anticoagulant. Current practice strongly favors DOACs because they are effective, convenient, and safe for most patients. The key exceptions include pregnancy, certain thrombophilic conditions, and some patients with advanced renal impairment. How long should treatment continue? Because this is a provoked event associated with a transient risk factor, 3 months of anticoagulation is usually sufficient. This is a common examination question and an important clinical principle. Our second patient is much more unwell. She has active malignancy, pleuritic chest pain, collapse, profound breathlessness, and severe physiological disturbance. At this stage, PE should be considered highly likely. The key message is that this patient may be dying from obstructive shock caused by pulmonary embolism. Always approach critically ill patients using ABCDE principles. The severe hypotension, tachycardia, and hypoxia suggest hemodynamic instability. The immediate priorities are oxygenation, monitoring, intravenous access, and urgent assessment for life-threatening causes. The blood gas demonstrates severe hypoxemia and respiratory alkalosis. The elevated lactate suggests significant tissue hypoperfusion. These findings support the diagnosis of a massive pulmonary embolism causing circulatory compromise. Although investigations are important, treatment should never be delayed in a patient with high clinical suspicion and hemodynamic instability. Therapeutic anticoagulation should be initiated promptly while definitive imaging is arranged. The CT confirms a saddle embolus. However, remember that management decisions are based primarily on physiology rather than imaging appearance. The key question is whether the patient is hemodynamically stable. In this case, the answer is clearly no. This patient has a high-risk pulmonary embolism. Bedside echocardiography may demonstrate right ventricular strain. Given persistent hypotension, systemic thrombolysis should be strongly considered unless contraindications exist. Early senior involvement is essential. Our third patient presents with unilateral leg swelling, redness, and tenderness. The clinical picture is highly suggestive of deep vein thrombosis. Remember that cellulitis is an important differential diagnosis. The examination findings support DVT. Clinical probability should be assessed using the Wells score for DVT. The Wells score helps categorize patients into likely or unlikely DVT groups. This guides subsequent investigation and management. It should always be interpreted alongside clinical judgment. For suspected DVT, compression ultrasonography is usually the definitive investigation. D-dimer testing is helpful only in selected low-risk patients. Once diagnosed, treatment is similar to pulmonary embolism. For most patients, ADOAC is now first-line therapy. Early mobilization is generally encouraged once anticoagulation has been established. This final case highlights one of the most challenging situations in acute medicine. Pregnancy itself causes breathlessness, tachycardia, and physiological changes that can mimic pulmonary embolism. However, PE remains a leading cause of maternal mortality. Maintaining a high index of suspicion is therefore essential. Investigation should be guided by local protocols. Chest X-ray remains useful. Depending on circumstances, either VQ scanning or CTPA may be appropriate. The choice depends on availability, local expertise, and radiation considerations. The anticoagulant of choice during pregnancy is low molecular weight heparin. DOACs are not recommended during pregnancy. Treatment generally continues throughout pregnancy and for a defined period postpartum. Thank you for your attention. The key messages from today are to recognize VTE early, assess clinical probability carefully, initiate anticoagulation promptly when appropriate, and identify patients with high-risk pulmonary embolism who may require thrombolysis or advanced intervention.